so much. And then do you guys know Lorenzo Petroni?
The name sounds familiar.
He's he's a European guy. He does like a lot of below the knee stuff.
Okay.
Anyways, I did an episode with him this weekend and he liked it so much that he asked for one. So there you go. Trucker hats.
For the viewers, are they on sale on the merch website?
I'm sure they are. Yeah, I'll find it. Don't worry about it.
So if you're filing in now for the Super Bowl 2024, we're just going to hang in for a couple more minutes while we get it set up on the live stream for BackTable, and we should be starting in 3 or 4 minutes.
Oh, it seems like we are live on YouTube as well.
So for the teams, between single and double jeopardy, we'll do a round of introductions, so you guys can get your names out there and where you're from and what year are you.
And what's your favorite IR procedure? No, I'm just kidding.
And your favorite color and your hobby. Turn into a biography.
Favorite attendant.
My staff found out I was doing this and they just kept calling me a nerd all day.
I don't think you're a nerd.
Bye. See you later. You guys should get an OBL because then your day will be over by 3 p.m.
If only it were that easy.
Well, what do you think, Sean? I think we can probably at least get started. People are gonna keep on joining in.
All right. Sounds good. All right, good evening, everybody. This is Sean Morato reporting in from University of Pennsylvania in Philadelphia. I'm joined by Jan Eppelbaum, who's going to be joining us from the Brigham, correct?
Yep, up in New England, Brigham and Women's Hospital.
Right, and we have Ali Behetti, a special guest star from BackTable Podcast.
Uh-oh.
What's that?
I'm just here to provide some color commentary, guys.
Yes, correct. But we're doing the first ever IR Super Bowl, which is going to consist of a competition, Jeopardy style competition between 5 residents from each region, from the New England Society of Interventional Radiology and the Philadelphia Angiography and Interventional Radiology Symposium. So PAIRS and NESIR for short. So hang tight. We got some pretty good questions. Hopefully a really good competition. Let's see if I can get here.
And I would just add, you may have missed the playoffs. All the other academic medical centers were knocked out in other playoff rounds, and that's why
we're the best of the best. All right. So bottom line is we're going to go over some quick rules here, just so everyone's familiar with why each person is answering when they're answering. So every team is going to have players designated with a number. The players within each team are different levels of training to incorporate all varieties of experience. We're going to determine the order. We already determined the order beforehand. We're going to go down the line with questions. So the first person in each team will get an opportunity to answer a question. If they get it right, it will continue down the line until the last player on the team answers. And if all 5 in a row get the question correct, there will be a point value bonus associated with that streak. Once the streak is over, the other team will continue and start their rotation. If the team that is going gets the answer incorrectly, the other team will have a chance to confer together and steal the question as well as the point amount. So this is a hybrid Jeopardy Family Feud situation. If the stealing team gets the question right, they also get the volley or get to choose the question in the next turn, and they continue their rotation from where they left off. Okay, again, we got the 5 questions in a row, results in a bonus. If the stealing team gets the question wrong, it goes back to the original team, but they do not get the team bonus if they do the streak. Every round will have a daily double, just like a traditional Jeopardy format. And that will include the ability to bet up to the amount that you currently have, which we'll be hopefully reporting regularly during the presentation if we can remember the totals for each team. And then if you get that wrong, the other team gets a chance to answer the question for the designated point value in the slot, not the bet amount. So the first round of Jeopardy, I tried to put Tom Brady's face in here, but it didn't fit. But we're going to have 5 categories, 5 questions each category, and it's a 100 through 500 point value. So the categories are medication reconciliation, which I'm sure you can imagine what those questions are about. Highways and byways, which is a vascular anatomy topic. Food and water, which is how we say water in Philadelphia. That will comprise alimentary, GI, and GU tract questions. Arterial intervention. And just put a needle in it, which is abscess and drain placement. Allie, what's your favorite one so far?
I mean, I can't say no to a good drain placement. It's just so satisfying to get all the pus out.
Exactly. All right, so we determined that the New England Society of Interventional Radiology will go first because they have the oldest team member, which is born in the 1980s, so it's not really that old. Okay, so go ahead, New England Society of Interventional. What are we going for first?
We'll take just put a needle in it for 500.
For the big guns.
The MedRec and the MedRec 100 and 200 are still open. I think you might have that might have just been clicked in the.
Yeah. Sorry, I don't know why that's clicked. All right, the 500 is going now. Urgent consult. 45-year-old heavy drinker has right-sided chest pain incidentally found on chest CT scan. The following was seen. Patient has normal vitals and labs are normal. He recalls some abdominal pain about 2 months ago, but that resolved after a few days. The ER calls you at 1 a.m. asking for urgent drainage. You tell the ED that the findings represent this.
The findings here most likely represent a pseudoaneurysm of the splenic artery.
That is incorrect. We are going to transfer over to the pairs group to see if they can steal the point value.
So the pairs team, you have the chance to confer and provide an answer.
Okay. Whoever wants to just say it.
I think it's a pseudocyst, right?
Yeah. What is a pseudocyst?
That is correct.
Oh, I almost cursed there.
You did.
So the bottom line is asymptomatic pseudocysts tend to resolve on their own and do not require intervention. This patient did not have any clinical signs of illness or sepsis or anything like that. Typically, they go away on their own. There are other methods to drain these as well from the the gastric lumen, like the cystgastrostomy. Alrighty, so
it comes to us, right, Sean?
Yes, it does. Yes. So Jan,
I would just say it's reasonable to have considered an aneurysm, particularly in a single slice image. You see a calcified, peripheral, fluid-filled structure. But yes, nice job with the pseudocyst.
Okay, pairs is up.
We can do just put needle in it for 400.
Oh.
So since you only have 500, you can only bet up to 500.
So the question for the pairs team. So 68-year-old with right upper quadrant pain and distended gallbladder with wall thickening and ultrasound. This patient is not a surgical candidate. There is also moderate ascites. So given these findings, is it okay to proceed with percutaneous drainage?
And I'm sorry, you said 500? you're betting?
Correct.
All right.
Wow. All right.
Go big or go home, right?
Exactly.
Relative contraindication to percutaneous drainage. So no.
So that answer is incorrect.
Correct. Yeah.
Ascites is not a absolute contraindication, apparently. So
Okay.
I think that the steal cannot happen here because
Yeah,
for NESIR. So
No steal on the daily double.
Yeah. Exactly.
then we would just continue on.
yes. So who goes now?
Are we there?
No. They keep
The box.
Okay. Yeah. Sounds good. I guess we'll do food and water 500.
Water.
Hey, it's from Philly.
So a life-threatening complication of chronic indwelling retrograde transileostomy nephroureteral catheters that requires emergent IR intervention.
Yeah, an answer. Time's running out.
Oh,
We have the timer up. Yep.
Okay.
All right, time's up.
I guess. Wow. Like a
Answer would be urine leak.
Incorrect.
Incorrect. Yeah.
I'm not even kidding you guys. This is the first case I had when I joined my group in Tacoma. So like you will see this IRL.
So can I start the 10 seconds for chance to steal?
Yeah, go ahead.
We've had 2 of these in the past 3 months. What is it here? Renal iliac fistula?
Congratulations. So that 500.
And these can be difficult to diagnose because sometimes they may only have hematuria when you're exchanging their tubes, or they may just have slow hematuria that's oozing. But then sometimes it really does start to hemorrhage massively when you are exchanging these, or they just rupture. So it's important to consider this, particularly if patients have radiation therapy, complex surgical histories, and a long standing indwelling catheter.
I also witnessed one that had a fistula to the vagina. So the artery fistulized with the vagina through because of the stent, and the patient was like exsanguinating that way. So it's definitely
Wow.
a scary entity to witness. All right.
So to clarify, does this start the streak of 5, or does that just the steal and now the new streak of 5 begins?
That started the streak of 5.
Yeah.
So 4 more.
Okay, so that's 1.
Yeah, that's 1. Who's next? NESIR.
Let's do food and water for 400.
This tube is placed by IR for a patient with a surgical history of cystectomy, ileal conduit creation with rising creatinine.
What is it, nephrostomy?
Correct. No tidbits there. Anything from you, Allie?
Well, I just actually forgot we were playing Jeopardy and you had to answer with what is questions. So
Yeah,
props to that. I'm not sure that everyone else was doing that before this. So good job.
We're giving them some grace periods to not get that. So all
And
right,
then
next.
should we just give a brief update on the scores? So
Yeah.
right now I have minus 1,000 for pairs.
It should be minus 500.
Let's
Yeah.
see. Because they missed the daily double. Well, daily double they lost everything, so they went to 0. Now it's minus 500 for the arterial case. Yeah,
Right.
you're right. Thank you.
And
Not trying
900.
to even though I know there's $1 million at stake here.
Just your dignity. It's fine.
Yes.
Next
Can I do highway and byways for 300?
This pathway is opacified in the angiography below.
The pancreatic duodenal pathway.
Incorrect. Back to pairs. Who's next to pairs? We good?
Arcabular.
That is correct.
Correct.
Nice.
The persistent embryonic anastomosis between the celiac and the SMA. And this can be seen when there's a celiac stenosis. Okay. That was 300.
That's 300. So they're minus 200. Yep.
MedRec is still available, everyone.
Nobody wants to do the medrec.
It's an epic. It's just epic questions about how do you run a child.
I'll go for highways and byways, 400.
Those are like the sexy questions, right? Everyone wants to do those ones.
Yeah. What was the value?
400.
400.
In this patient with aortoiliac occlusion or Larice syndrome, these two arteries are denoted by the arrows.
Winslow back.
Okay, time's up.
Oh.
You got an answer?
A foramen of Winslow pathway, superior epigastric collaterals going through inferior epigastric.
That is correct.
So just a little core tidbit. The Larice syndrome, defined by aortoiliac occlusion, can present as absent femoral pulses, bilateral claudication, and impotence. So that was 400.
Evident too.
Yeah.
Bonus points. Okay.
Next question.
Could I do arterial intervention for 400?
I like how you guys are picking like the big number ones first. That's bold moves, even though you're not getting them right, but you're just picking them. I love it.
Mic drop.
So this is a 28-year-old female who's presenting with an acute GI bleed and has been suffering from weeks of intermittent fever, weight loss, joint pains, and skin ulcerations. Angiography demonstrates the following diagnosis.
What is scleroderma?
No, that is incorrect. We'll pass it back to New England.
What is polyarteritis nodosa?
That is correct.
Nice work.
So it's a vasculitis affecting small and medium-sized arteries, and you commonly have involvement of the kidneys, skin, bowel, joints, and muscle.
I'll do highways and byways for 200.
The artery highlighted below is the
Let's say what is the marginal artery?
that is incorrect. Steele?
Did we lose you guys? We couldn't hear what was being said.
That the other team or me?
Both. Did they answer or?
Yes, they did.
Oh, yes, so you have the opportunity to steal.
Okay.
Okay, sorry, we didn't know they got it wrong. Okay.
So
Wait, what they say?
What did they say? We couldn't hear what they said.
Well, this is quite the pickle. I mean, if you can have audio problems, you would have some insight. I don't know what we should do here, Sean. Should we tell them what the?
I don't think so. They
Nah,
weren't paying
man, that's
attention.
on
They've
them.
had plenty of
That
time to
is
think.
on them.
Yeah, I mean, on the boards, no one's going to be telling you what the
Yeah.
other person got wrong.
That you have an equal opportunity to get it wrong as the other team.
Okay, you guys ready? Yeah.
let's see. Arterial.
That is correct.
I really experienced this.
Yes. Can we maybe have them speak up a little bit more?
So this is anastomosis between the SMA and the IMA, arterial.
Okay, so next.
Let's do MedRec for 400.
Yeah, MedRec. Oh my God, so much words.
You're performing a PE thrombectomy, and as a result of intraprocedural heparin boluses, a patient's ACT is greater than 300 upon measurement. After about an hour during the thrombectomy, the patient develops significant hemoptysis. Your team acts quickly to turn the patient decubitus position on the side you're working. At this point, you decide to deliver this medication to help stop the effect of heparin.
Time is up.
So no.
No answer?
Can we steal?
Yes.
Yeah, what does proto mean?
That is correct.
All right, back to NESIR.
All right. Can we get arterial intervention for 300?
Wow.
Patient presents with massive hemoptysis and you're asked to perform a bronchial artery embolization. This looks like a splenic artery. Here is the bronchial arteriogram. If you embolize from this position, your patient will be at increased risk for which complication?
Bonus points if you can spell that artery.
You'll be at risk for like spinal cord damage or like off-target embolization.
What do you think, Jan?
So they said spinal cord damage.
I'm going to say yes.
I mean, I think that's close
I'm
enough.
going to say yes. Yeah.
Yeah. Because that's true. That is very
That is true.
That's a question I accept.
And then how do you spell the artery?
Oh,
Bonus 1,000.
So the artery of Adamkiewicz anastomosis with the accessory anterior spinal artery. So if beads can escape into that, you can result in spinal cord ischemia, which can result in paralysis.
How did you say that again, Sean?
Adamkiewicz?
That is 1,000% not right. Is that right?
is.
Oh, it is?
I think
Oh,
it's-
wow.
yeah.
Sorry, Sean.
Oh, how do you say it?
What do you say? Duodenum or duodenum?
We call it the dude over here. All right. Next question. NESIR. They're running away with it right now. They're running away with it.
Arterial intervention 500.
Cool, buddy. You sure about that?
Diagnosis, please.
Time's up. Do you have an answer?
What is cystic medial lysis of the popliteal artery?
Jan?
I would give that. What do you think?
Yeah, sure.
Otherwise known as accident disease. Now, if you have gripe with our questions, please do not complain. We did the best we could to make them the right
Guys,
answers.
these questions are so good. Are you kidding? And like the images you picked are amazing. Like you should write a textbook if you haven't already, or if you stole those from a textbook, that's also
some of them.
fine.
Yeah, we have references at the end because a number of them did come from textbooks, and so yes, we're grateful for that.
So NESIR has answered 3 correctly in a row. So 2 more for a streak.
Get
that streak.
The score right. I have to do some mental math. So just while Jan, can you read the next question?
Absolutely. So what's the next question that's being selected?
Yes.
Oh, I don't know. Oh, well, what is NESIR choosing?
We're choosing Spoladino and 300.
All right. So Sean, I'll need you to actually select it because I don't have the control.
What is it?
Put a needle in it at 300?
300. So 45-year-old who had a case of diverticulitis complicated by intra-abdominal abscess and had a drain placed 4 weeks ago. On abscess drain checkup, you see the pictures to the right. The post-injection image shows this finding.
What is it? Abscess fistula?
I'm not supposed to judge NESIR, so Sean, I will defer to you.
That's correct. That's correct.
Okay. Quick question. What do you guys call this type of exam when you inject a drain? What is the name of that exam?
In New England, we call it a fistulogram.
A fistulogram. All right,
Just
but
kidding,
not
just
like
fistulogram.
a dialysis fistulogram.
Yeah.
Okay.
How about a drain check? A drain check for 500?
Drain check.
An abscessogram. We call it an abscessogram where I'm from.
Abscessogram.
Yeah.
And my first job in Wisconsin, they called it a sinogram, and I had no
Sinogram.
idea what that was. Have you guys heard of that before?
Yeah.
I've heard sinogram.
Yeah, I've heard of that.
I heard sinogram.
Skin, but
A drain check by any other name.
So the bottom line is a very important finding to make on a drain check because it can and that as we know, drain checks are very glorious and drain placements are very glorious, but for patients, drains for a long term are very, very annoying. So the faster we can get them out, the better. So it'll definitely guide your management on whether you should change it, stop flushing, etc. So this is a really good question. So the score update is NESIR 2500, pairs, goose egg. That's a
Ooh.
0. Yeah. So we have 4 questions correct in a row by NESIR. They're going for the streak bonus.
All right.
And I just want to say, pairs, still, I mean, you have double jeopardy,
Yeah,
you
yeah.
have final
This is not
jeopardy, it's still early days.
Jan, you're so supportive.
So you're telling them there's a chance?
That's why we play the game.
All right, so NASIR for the bonus.
I'll do arterial intervention for 100.
Excellent strategy. For angiographic purposes, the popliteal artery can be divided into 3 segments. These 2 anatomic structures delineate the cranial and caudal margins of the first segment.
The TP front. I'm not sure.
I'm sorry, what?
The tibial peritoneal front.
That is incorrect.
Sure.
Maybe like condyles.
So pairs has the opportunity to steal.
Condyle.
also lose points if we get it wrong. I feel like we should.
Yes, yes.
Oh, okay. Wow.
Oh, you guys? No. The steal does not lose points.
Yeah.
If it's wrong. No.
Answer, guys.
Femoral condyle. Tibial.
That
No, wait.
was real.
We need an answer.
Femoral condyle and tibal plateau.
Incorrect.
That is incorrect.
So we go back to NESIR and we just can't scrap the question.
Just scrap the question now.
Yeah, let's scrap it. Yeah.
You can show them the answer.
What?
Show them the answer.
The adductor hiatus, which is the beginning of Hunter's canal, and the top of the patella delineate the first segment of the popliteal artery. That probably should have been a more difficult.
Yeah,
That
should have
was
been
kind of a tough question, guys.
That should have been a $500 question. Yes.
Yeah.
I gotta be honest, when I read this question, I was like, I have no idea.
Didn't we go to the same residency?
Well, I don't think Alex Trebek knew all the answers either, so don't even worry about it.
There you go. All right, so now it goes back to NESIR because but their streak is over now.
Oh,
Yeah.
yeah. Okay, great.
So they get one more question and then it goes back to pairs.
Okay, sounds good. I'll do food and food for 300. Oh, 300. Okay.
The threshold size to consider for IR intervention in asymptomatic patients.
What is 4 centimeters?
Correct.
Nice.
So-
Very confident. Very good.
So I actually thought that I found an interesting, I don't know where the paper was from, but there is now some question about whether or not you can look at it at 6 centimeters as the cutoff, and also the percent fat content in the actual tumor itself. So I don't know if there's any particular parameters for the fat content, but I thought that was an interesting fact. I'm sorry, did I put the wrong one for you guys?
That's okay, yeah, it's fine.
Sorry, I didn't hear it correctly.
No worries.
So I guess would it come back to us now, Sean?
Yes.
Okay. Whoever's next on.
Rec for 300.
1 and 200 are still open. I don't know why they're grayed out.
During placement of a routine chest port, you notice after wire manipulation and a couple of unplanned wire passes into the ventricle, the patient's heart rate jumps from 78 to 80 to 140 sustained sinus tachycardia with a normal blood pressure. You attempt vagal maneuvers unsuccessfully. This agent is then administered intravenously, which results in return of heart rate to baseline.
What is adenosine?
That is correct.
Just a fun fact, adenosine was actually invented at UVA by Bob Burns. Don't ask me how I know that, but yes, now you know that too.
Did he plan that invention or?
Oh, that's color commentary.
Alrighty, let's do, just put a needle in it for 200.
Streak.
I have a heckler coming in from outside, Don Garbett. He says you guys need to do better. And his group might be hiring. No, I'm just kidding.
We didn't agree to that kind of commentary. Wait a second.
This is also reflective, I think, of board questions where you're having to show the arrow of how you place the drain. So which route would you take in this 34-year-old with left upper quadrant pain, fevers, and leukocytosis to 23? The CT demonstrates the following finding. So which route would be safest and most comfortable to the patient?
That is incorrect.
What did it say?
That doesn't look super comfortable because you have to go through a lot of paraspinal muscles.
Yeah,
And
yeah.
it
Chance
sounds
to
pretty
steal?
painful.
Chance to steal. 10 seconds.
For IR, it would be B. If you ask GI, it would be A.
There's no bonus for that kind of answer. All right, NESIR. So just as Ali had mentioned, D would be uncomfortable. It's a posterior drain. C would be, this arrow puts it right through the bone. I don't really know if that's the case, but if you go intercostal, obviously it would be painful. And if you go percutaneous, you'd be doing a percutaneous cyst gastrostomy. Next question.
All right, we get food and water for 300.
By the way, I love how everyone's saying it. That's so great.
Wait a second. That's not an angiogram. Wait a second.
Single best tube for a patient with gastroparesis, seeking both decompression for obstructive symptoms and enteral nutrition.
Let's go with Doloff too.
That's incorrect.
But not anymore.
Doboff tube. Ugh.
Percutaneous gastrojejunostomy or GJ.
That
is correct.
How much was that? That's 300.
That was 300.
Have you had nukes yet?
I did. Very beginning.
All right. Pairs, first of 5. Got the steal, starting the streak.
Really good thing I didn't bring beer. They're getting real rowdy.
So pairs, your time to choose.
I'll go for Medrec 500.
We have Don Garbett answer this question.
I guess like
All right.
you have like a guest shot from Don.
So while performing venography with a medical student, you encourage them to perform the next image acquisition by hand. They anxiously grab a liquid-filled syringe and inject it under fluoroscopy. No contrast appears on the screen, and the patient begins to develop seizures while setting up for the next injection. This substance was likely introduced intravenously by direct injection. So I think the question is, what is the substance here?
Local anesthesia? Lidocaine.
She did say
Lidocaine.
lidocaine.
That's correct. That is correct.
Nice.
So I have right now pairs is at 900.
That's correct. That's what I have as well. And NESIR is 25.
Correct.
Yeah. Okay. 2,500. Okay.
So yeah, 2,500, not 25. Yes.
All right. Pairs.
Can we do arterial intervention for 200?
In proximal splenic artery embolization, the appropriate position for placement of your embolic of choice is between these two arteries.
What is your pancreatic magna and your right gastric?
What do you think, Sean?
I say no. I say.
Yeah, I would agree. I would agree.
My bad.
It's a steal. What are the dorsal pancreatic arteries and pancreatic magna artery?
That is correct. All right, back to NESIR.
High waist and wide waist 500.
This arterial variant, persistent embryologic structure, is present and places this patient at increased risk for vascular injury.
Oh man, everybody knows in attending who this is their favorite normal variant. You know?
I've been on the receiving end of that one.
Answer, please. What is the crown of death?
Incorrect. Pairs for the steal.
Go ahead. Oh, is that me?
Is that us?
Is that you,
Yeah,
Sean?
yeah, pairs.
Yeah,
for the
so
steal,
pairs,
yeah.
yes, pairs. This is your golden opportunity to
Yeah.
take control of the game and try to steal.
Yes. Come on, Paris.
Did you hear the answer?
Did you hear her?
Not what you say.
Oh, persistent sciatic artery.
Correct.
That is correct.
All right. So the gap is tightening.
And I think the important thing to notice here is that when you're looking at this CT, there's an asymmetry in the common femoral arteries or the external iliac arteries bilaterally. You don't even see it on the right, but you do see it opacified on the left. And you lower down, if you were to see the CTA, you'd have a hypoplastic SFA, and then you have that persistent sciatic artery where the arrow is pointing to.
So you can get aneurysms, I think, is the main thing when you have repetitive mechanical stress to it.
Just an update from our friendly heckler Don Garbett. He would like to say that whoever missed that G-tube, the GJ question, needs to place all the G-tubes for the rest of their residency. He's apparently also heckling on YouTube, in case you're interested.
Yes, we're up, right?
Pairs is up.
Yeah, it's
So MedRec 1 and 200 still available.
Let's go MedRec 200.
All right, you hear an overhead page, rapid response to CT scan, rapid response to CT scan. As a patient undergoing a CT becomes unresponsive 5 minutes after IV contrast bolus. You suggest to administer this medication to address the hemodynamic changes.
Is epinephrine?
That is correct.
Somebody just took ACLS. I hear that. All right.
I actually had that in the question and then removed it because I wouldn't torture someone that way.
Not on a 200 question, right?
How many
Yeah.
zeros are in the dose?
MedRec 100.
During a routine bone marrow biopsy, you notice that the patient's respirations are 8 and O2 saturations are 70% after administration of moderate sedation. You consider this medication either to address the effects of the sedation.
Naloxone.
That is correct. And flumazenil also could be an answer here as well. So right now I have pairs at 1,500 with this streak.
Here we go. Here we go.
Just put a needle in it for 100.
So this is the opportunity for the bonus. Right, John? No?
No.
Is this the 5th?
This is only the 3rd for us in a row.
Oh, okay.
How big would you go? This is a 55-year-old alcoholic coming in with abdominal pain, early satiety for several weeks, intermittent fevers, and a white blood cell count of 20. CT on the right shows large complex pancreatic collection.
I feel like this is a little subjective, this question. You know, I feel like it could go a lot of different ways. I'd be interested to see what you guys say.
I'll go 10 to 12.
That is incorrect. Per NESIR pairs criteria.
The answer composite.
Chance of steal?
Chance of steal.
I mean, you wouldn't go through your kidney, right?
No.
What is the 14 to 18?
That is incorrect. We're going big here because pancreatic necrotic collections are often very complex and drains you put in become occluded rapidly. And given the negative effects that it can cause to the patient in a quick way, we want to make sure that we decompress it as best as possible. Allie, what is your input on this?
This is how I feel too. I feel like a collection like this would require a big drain. I will say in practice, a lot of IR doctors are hesitant to put in a large drain as the initial step, and they'd probably start with like a 12 and upsize. So I could see that going either way.
2 more clues.
Yeah, and I think I agree. I mean, I think there's definitely a lot of that's a much more nuanced question than the slam dunk. Like you see an angiographic finding and you call the diagnosis.
Sure.
No one would be wrong putting a 10 to 12 French drain in this, but they must understand that they may have to, or most likely will have to upsize it at some point.
Or their partner would, yeah.
Immediately.
All right, Pairs is back with this will be their 5th question, right? Or was that their 5th question?
No, I think. I guess that, but we didn't get the streak. But it would be like it's still our turn.
This question will be their 5th question.
I see. So then it'll go back for the last question.
Correct.
Okay. 2 more clues.
Is MedWest 100 still available?
No, that we did that already.
Now you guys love MedRec. Yeah, when the game started, no one loved the MedRec.
Where are we going?
Is MedRec still available?
No, it's not.
Oh, it's not.
I think it's Pairs' turn.
Pairs, where are we going?
Pairs turn. Yes, Pairs turn. Yep. There are 2. It seems like there are 2 questions available: highways and byways, and food and water.
Highways and byways.
The blue arrow denotes this structure on the provided angiogram.
Replaced right. This is a replaced right.
If you can be more specific, replaced right.
Hepatic artery.
Correct.
Your brain said it, but your mouth didn't say it. I've been there, man. I get that.
And this is one of the more common anatomic variants occurring in up to 15% of the population, most common hepatic artery variant.
So now NESIR's turn, correct?
The final clue of single jeopardy. The most likely branch off the aorta that will show this pathologic finding. That will provide this pathologic finding.
And is this for NESIR?
This is for NESIR.
Okay, I just want to make sure everyone was aware. All right.
Main branch of the.
We're not muted.
Oh, sorry, let me mute it, sorry.
Answer, please.
What is the SMA?
That is correct.
What is that?
So you see the contrast layering for a GI bleed in the small intestine, so superior mesenteric artery. All right, so
Score update.
score update. Jan, you got it?
So I have 1,500 for the pairs team.
Okay, yeah, I got that too. And then 2,300 for NESIR. Okay, so pretty close going into double jeopardy. Anyone's game.
Man, I feel like, guys, I feel like you're getting more confident as these questions go on, and you're answering more and more of them right. So
Alex Trebek is a troll.
Maybe don't pick all the 500 questions first. Just a tip.
All right, so let's go down the line and introduce ourselves here for the guests. We really first of all, we're very thankful for all 10 of you volunteering your time. Late at night, middle of the week. Some of you may or may not be on call. I don't know, but we'll start with NESIR. Going from left to right, raise your hand. Tell us who you are, where you're from, and what level you are.
Ryan Coffin, Boston Medical Center, IRDR 4.
Kay Zhang, Friggin, IRDR R4 as well.
Min Wen R2, IRDR R2.
Or I like this.
Already in the team. I'm from Michigan. And I'm an R2 IRDR also. And Ravish Patel, I'm in Atlanta, Georgia, at Boston Medical Center, IRDR 1.
Excellent. All right, pairs.
I'm Victor. I'm at Jeff, and I'm a PGY5.
I'm Drew. I'm a Penn. I'm an IRDR2.
Hi, Rashi. I'm an R2 from Mercy Catholic Medical Center, DR.
I'm Will. I'm a PGY5 from Temple.
Wait, we skipped one.
No,
Nope.
we're still going to.
Who's to your left, Will?
That's Mike.
That's me.
He's in attending at University of Pennsylvania, UI 9.
UI 9.
All right, Will, what were you saying now?
Oh, and then this one.
Yeah, I'm Hank, IRDR R2 from Philadelphia at Jeff.
Right on.
All right. And they're
Hey,
all
guys.
Thank you all for participating. This has been a great start, and I really appreciate you taking the time as well to have fun, to learn, and take time out of your busy day.
These questions are great, Sean and Jan. I'm pretty impressed by the work you put in here.
It was a group effort. We had joint work between NESIR and pairs, many meetings. I think we got to know each other quite well over the past 10 years as we were working on this one event.
I'm gonna hop off and hop onto my phone, so you guys I'll still be on audio, but I'm gonna have to drive to the airport. So nice to meet you guys. Good luck on Double Jeopardy.
Safe travel. Thank you.
Thank you. Nice to meet you.
All right, everybody. So here we go. Double Jeopardy. The values are all doubled. Okay, there's still a daily double up for grabs in an unknown position. And we're going to get started. Okay. Topics are veins, all sorts. Trauma alert. Not just positive HIDAs. cancer killers, and Ansef, which is basically a troll on ortho. All right, so the last clue went to NESIR and they got it correct. So
Wait, we got it because they started last one.
That's true. Yeah, so I think because NESIR started.
Yeah, right. So we're starting
the pairs would start.
Tom Brady here.
Deflate gate. All right. All right, pairs, you're up.
Who's have you trauma lit for 400?
Temple. Let's do it.
Hopefully not.
So vascular injury, please describe the identity and anatomic location shown in this trauma patient.
Oh, it looks like there's on the angio, what is like is that a corona mortis on the right with a blush?
That is incorrect.
Chance to steal. Time's up. You guys have an answer? Or is it an obstructor?
What was that?
They got it correct.
Okay, incorrect.
That's not what we're.
I'm sorry, I can't hear you guys.
They said obturator injury.
Okay, thank you, Dave. That was very nice. Okay, that's incorrect. So as shown, there's a linear filling defect in the right external iliac artery, which represents a dissection given the luminal irregularity. All right.
That was a tough one. That was a tough one.
I couldn't arrow sign that one. It was just, it would have just given it away. That was more of a find me situation. Who's up next?
Wait, stays the pairs, right?
Yeah, pairs.
Yes.
Stays with pairs.
Just kidding.
Let's do Ansef for 400.
That was pretty good the way you said that.
Bro.
In this 43-year-old patient with metastatic renal cell carcinoma to the bone, this embolic agent would be ideal for preoperative embolization.
C, do not proceed.
That is incorrect.
Chance to steal. Particles.
That is correct. Jan, why do we do that?
So yeah, the purpose of the embolization in this setting is to minimize blood loss intraoperatively for the orthopedic surgeon. So there wouldn't be a contraindication to using particles here. You of course want to use and calibrate the right size. Coils would lead to proximal occlusion, so you wouldn't really have a good distal effect. And there wasn't anything on that single image to show that there was a problem with causing embolization there.
Any second choice?
Veins of all sorts for 400.
A 72-year-old woman presents with new left lower extremity swelling and a history of a previously treated left lower extremity DVT. Given the repeat thrombosis, you decide to evaluate for this vascular anatomic entity.
Answer, please.
Pseudoaneurysm?
Pseudoaneurysm, you said?
Yeah.
Incorrect. Pairs chance to steal.
Okay. What is May-Thurner anatomy or syndrome?
That is correct.
That is correct.
There's a compression of the left iliac vein by the right iliac artery in May-Thurner syndrome.
what is it?
Turner?
Yeah. Oh, shoot.
Yeah.
Adam Kawitz?
Adam Kawitz and Mate Turner.
Yeah.
I'm pretty sure there's an H in it. I'm just.
Yeah, I that's the way I was taught as well.
Yeah.
So right now I have pairs at 1100.
Spelled that way, but.
And NESIR at 1900.
Yep.
We also teach pronunciation, I guess, in this. Well,
My own team is literally putting me on the coals right now. This is brutal. This is brutal. All right.
Cancer killers for 400.
The eager medical student responds, cool, do you have to get to the edge of the tumor or go beyond? And by how much?
Sorry, I forgot to put, this is referring to a cryoablation.
So really a question about how much beyond the border do you have to go?
What is 0.5 centimeters?
That is correct.
Excellent job.
Okay, I'll do veins, all sorts, for 600.
So during workup for an IVC filter replacement, you notice that this patient's variant anatomy. After much deliberation, you decide to place the filter apex at this location. So in your answer, please state the letter at which you place the filter apex.
I mean, I would go with A.
That is incorrect.
A. What do you say? Chance to steal?
Chance to steal.
What's your answer? D.
That is correct. So in this patient has multiple accessory renal veins, and we want to exclude all of them when we're putting an IVC filter in, so long as the filter does not extend into only one of the iliac veins. Otherwise, you have to consider putting filters in each iliac vein if it's too low. All right, NESIR.
I'll do not just positive HIDAs for 400. What are the scores? Can we get a score update, please? Awesome.
What's that?
Score update if we can.
The score is, and correct me if I'm wrong here, Jan, pairs at 900, NESIR at 2,500.
Correct.
So you can bet up to 2,500.
I'll do 500.
Okay. With a prevalence of 15 to 20%, this is the most common intrahepatic biliary duct anatomic variant.
Time's up. What is a cholecystectosis cyst?
Incorrect. Chance to steal pairs.
What is a right posterior ductal sectoral duct to the left?
That is
correct. So was this what point value was this?
500 was bet. Yes. So
no, they can't steal daily doubles. Remember?
No, but they can get the point value that the tile would have been. That's what we talked about in the beginning.
Okay.
It's the 400.
So that was a 400 point question.
Oh, I see. Okay.
So is it to us or is it back to them then?
Oh, I think it's us, right?
That's a steal,
We lost
technically.
the daily
Okay,
double.
so it's pairs.
Yeah, I don't
They
think
should go
they,
to
I think you can
pairs.
steal on daily double.
Yeah, I think it's a bonus, so they continue.
Oh, I see. So they don't get okay. So NESIR continues. My bad.
Yeah. All right.
let's go trauma 200.
Blunt force trauma often results in this injury process seen in the images provided.
Answer.
Let's go with like injury to the splenic artery causing infarction.
Jan, what do you think?
That is a potential answer, but I don't think that's the correct answer in this particular case.
I agree. So Pear's chance to steal. That was incorrect.
They want a specific answer, that's why.
What is a shattered spleen?
I'm gonna put this one out to the people in the rooms.
Is that grade 5? I don't think there's extra.
It's a strict definition for shattered.
Yeah, I think that's also not necessarily the finding here, although that would be on the spectrum.
Yeah.
What is, you would say, hey, trauma, we're being consulted for.
Grade 5 splenic lac.
So we're just gonna throw this one out, I think.
Yeah.
So it's a splenic laceration.
We won't count this for either team.
I agree. Yeah. So the important fact to remember about splenic lacs, especially with AAST guidelines, is when is it okay to tell the surgeon at 3 a.m. that they should take their spleen out? Okay, and if the patient is hemodynamically unstable and the splenic, and I don't know if Dr. Cuthbertson can jump in here because she sees a lot of these, but if hemodynamic instability is present and the patient is doing very poorly, it's okay to lobby for a splenectomy.
Agreed.
And that's even at 3 p.m., not just 3 a.m.
Trauma surgeons probably won't accept it for either time of the day, but
So yes, shattered spleen is on the spectrum of splenic lacs and also a splenic artery avulsion. The reason why the avulsion is probably incorrect here is because there is some perfusion to the spleen still, and a shattered spleen, I think, would be actually like in pieces. Is that okay to say, Em?
yeah, I mean, you see the splenic art. Yeah. Yeah.
Who's up? Maria? Okay.
All right, let's move it along here. Doing great.
Trauma 1000, please. Big.
The commonly used Latin name for the vessel shown with active extravasation.
What is the corona mortis?
That is correct. That's a solid insurance.
Big money.
The corona mortis represents the anastomosis between the external iliac artery and the deep inferior epigastric and obturator artery. I did see in a short search that actually in a random study of 100 CT scans that it can be present up to 1/3 of patients.
Let's do veins all sourced for 1,000.
Yeah, we'll do a score check. Your highly communicative and readily available colleague from GI presents these images from a scope they performed prior to a patient developing massive hematemesis and hemodynamic instability requiring massive transfusion. Upon further questioning, you elicit that the esophagus was clear of similar abnormalities. At this point, you offer this procedure.
What is a BRTO?
That is correct. We would have also accepted a Parto in this instance. All right, Jan, I have NESIR at 4,000.
Yeah. I have Philly at 1,300.
correct. All right, how many are we on for streak? Is that 2 or 3?
I think that was 2.
Okay.
Yeah.
Two, but I don't think they're eligible for the streak.
Oh, because
so they have 3, I think 3 answered in a row.
Okay.
But not eligible for the streak. They can get 2 more correct and then it reverts.
Okay, got it. Thank you, Dave.
Yep.
Oh, okay. All right. Let's do veins almost off for 200.
While performing a tunnel dialysis catheter exchange due to sluggish flows from HD, you perform a pullback venogram and the provided finding is the result of this entity.
Answer, please.
Some SVC stenosis.
That is incorrect. Pair's chance to steal.
What is a fibrin sheath?
That is correct.
Nice. Good job, good job.
And the way you could treat this, you could perform balloon venoplasty or use a snare to try to strip off the fibrin sheath.
Is yours? Oh. Go ahead and choose.
I choose vein and all sorts, 800.
45-year-old female patient presents for cardiac workup and is found to have an ejection fraction of 25%. The patient also has a pediatric seizure disorder, which is well controlled. On exam in her oral cavity, she's noted to have few purplish spots. This is the likely culprit for the finding on the provided radiograph.
HHT.
Yeah.
Yeah, come on, that's right.
I mean, I think, yeah, that does kind of bring everything together.
I see your true colors.
I think it's correct. I think I think so. Can you tell us
she's
what's
not wrong.
on the X-ray? Can you tell us what's on the X-ray?
It's opacity, which likely could be a pulmonary AVM.
Okay.
Yes, that's correct. Yeah.
Yeah, because you're
When are we going to rename those pulmonary AVFs?
ABS.
That's what they are, right? AVF.
All right, pairs up again.
And I do and Ceph for 600.
This arrow represents the safest percutaneous approach to sample this destructive osseous lesion. So just state the color of the arrow that you would take for sampling this.
I'm assuming we want the kind of like soft tissue component. I would go with the green arrow.
That is incorrect.
Chance to steal? What's the yellow arrow look like?
There is no yellow arrow on this question.
Orange.
That's yellow. Dude, that's yellow.
Hey.
What is goldenrod?
Golden rod.
It's like
Amarillo.
like a dark golden. All right, so I'll let you decide on that answer.
That is correct.
I did not know you were a Crayola expert, Dr. Applebaum.
I am. I have a 5-year-old. I have to.
So I think while the green arrow does avoid the epigastric arteries, they're not often that easy to see on CAT scan. And there is a soft tissue component through the gluteal muscle. So this patient would be prone and they would get the Amarillo goldenrod arrow.
We stole that. Yeah, we stole that. I'll do cancer killings for 200.
Cryoablation is being performed. 63-year-old with a left RCC presents for cryoablation. CT images show the findings. As you prepare the cryoprobes, you proudly instruct the medical student on service that it is at this temperature that malignant cells die.
What answer, please?
What is negative 40 degrees Celsius?
I forget the answer to this.
That is incorrect.
Okay.
And Pears has the opportunity to
So where's the wine dining?
What is zero?
That is incorrect.
That is incorrect. And you have to state actually what measure. Is this Kelvin or no, I'm just kidding.
Negative 20 degrees Celsius.
Prostate is negative 40. RCC.
Can we just do a score check? I have 3,600 for NESIR.
Yeah.
And then would it be 1,700 for Philly?
Exactly.
They didn't steal it.
They did not steal.
What number is this now?
This might be is this the last one NESIR gets to answer?
I don't know.
I think so.
All right, last one for NESIR, whether it's right or wrong.
Strong one for 600.
This intervention should be considered in the setting of the traumatic injury shown below.
Answer, please.
Aorta iliac stenting.
That's correct.
Nice. Good stuff.
So a traumatic aortocable fistula seen in the prior video, which I think is a fascinating video, by the way.
It's a nice image.
Was it Emily that shared this angio?
What's that?
This is Emily, right?
Emily did, yeah.
Yeah, thank you to Emily.
When a person has a aortocable fistula, they are at high risk of developing high output heart failure if they don't die from hemorrhagic shock.
So was that 5 then for NES?
Yeah, that's fine. So a pair's turn.
Whose turn is it next? Oh.
What are we doing?
Let's do
Pears is up for a question.
Yeah.
Not just positive HIDAs for 600.
Yeah.
Portal hypertension is a clinical syndrome characterized by ascites, splenomegaly, gastrointestinal varices, encephalopathy, and is defined by a portosystemic pressure gradient greater than.
What is 10?
That is
incorrect.
Correct for the purposes of this question, of this strict question.
No, that's incorrect.
Incorrect.
Incorrect. Yeah.
Incorrect.
Chance to steal?
Chance to steal.
What is greater than 5 millimeters mercury?
That is correct. So in terms of actually defining, the gradient, it's when it's greater than 5 is when you have portal hypertension. When it's greater than 10, that's when you're concerned about clinically significant portal hypertension.
As shown by table 1.
It's 800. Nice.
A young athlete with positional pain and numbness of the upper extremity. The below functional MRA supports this diagnosis.
What is arterial thoracic outlet syndrome?
That is correct.
So that's 2, right? It's
Yeah.
2 correct?
Yeah.
Sure. Okay, yeah. Let's do
Cancer killers for 1,000.
A 67-year-old HCV cirrhosis with hepatocellular carcinoma in the right hepatic lobe presents for a TACE. During a preoperative workup, the patient remembers that in the past, he had a procedure where they cut open a sphincter in my bile ducts or something. On CT, you see cholecystectomy clips and a hepatic tumor, but otherwise unremarkable. No evidence of biliary dilation. Which medication do you want to make sure to prescribe both pre and post procedure? It's the same medication in the parentheses.
What is ceftriaxone flagyl?
While I believe that's an acceptable answer, it is not the single best answer.
There's evidence to support a single best agent.
Answer from pairs.
What is moxifloxacin?
That is correct. Moxifloxacin has really good biliary excretion, so it's a good prophylaxis.
Was published here, actually.
Jan, 4,600 to 2,100.
Exactly. Yep, that's what I have. All right. So it's up to
Pairs. Pairs are up.
All right, not just positive heights for that.
Let's see.
in the setting of a known lymphatic ascites after pancreaticodenectomy, Whipple, hepatic lymphorrhea is suspected when acidic fluid analysis is high or low in triglycerides and high or low in protein. So you have to state for this answer whether triglycerides in this context would be high or low and whether protein would be high or low.
What is high triglycerides and low protein?
That is not correct for the purposes of hepatic lymphorrhea.
So for the steel, what is high in triglycerides and high in protein?
That is incorrect. Low triglycerides and high protein. Can someone explain to me why low triglycerides would be the case?
It has not taken the lymphatic fluid from the gut yet.
Oh.
So why is it called lymphorrhea?
There you go.
That's what we called it in the paper.
That's why it's 1,000. It's even tougher for attending.
Yeah.
I reference Steve Guess et al. 2014 JVIR abstract.
So for that one, pairs loses 1,000 and NESIR gains 1,000. No, it loses. They don't lose anything.
They both lose. They both lose.
Wait, no. The steel does not lose.
Why do we get punished?
Oh, the steel doesn't lose. Okay, I'll give you your money back. No refunds here.
Steel is just FTW.
Wait, so then which team was it that tried to steal?
NESIR tried to steal and pairs
Okay.
picked the question.
Okay, got it.
So it's back to pairs.
Yeah.
But they're the only ones that lose points.
Yes.
And we're telling Max Itkin that the pairs team got it wrong.
Okay, pairs is up, right?
Yep, go ahead. We'll do cancer kills for 600.
52-year-old with neuroendocrine tumor, liver mets, comes in for a TACE. The procedure is uneventful and successful. 30 minutes later, the nurse from post-op calls and says the patient looks very red. When you go see the patient, he says he feels super hot, all over, nauseous, and unwell. The patient has stable vital signs that are within normal limits. What is the likely diagnosis, and what would you use to treat?
Okay, sympathetic storm. And I guess. I don't know, beta blocker.
That is incorrect.
Yes, Steele.
What is carcinoid storm or syndrome and treat without treatment?
That is correct.
So you can have symptoms of flushing, diarrhea, bronchoconstriction. The crisis can precipitate where you have hypotension and arrhythmia, and it occurs in the setting of neuroendocrine tumors, and you treat it typically with pre-medication as you anticipated with octreotide.
All right.
Not just positive titles for 200. Let's see.
This anatomical structure, an embryologic remnant, could contain a replaced left hepatic artery.
The umbilical artery.
That is incorrect. Pair's chance to steal.
Logic remnant, though.
It's not the falciform, is it?
I don't know the answer.
You wanna try? What's the falciform?
That is also incorrect.
Oh, it's good content.
The ligamentum venosum can contain a replace left hepatic artery.
Oh.
5,000 to 1,100.
Correct.
So we did not lose points on that, correct?
Correct.
You didn't lose points on that, no.
All right, I'll do ANSA for 200.
This diagnosis, along with the provided angiography, could explain a 25-year-old patient with calf claudication.
What is popliteal artery entrapment syndrome?
That is correct.
All right.
It's all high rollers now.
4 left.
Trauma 800.
The specific name for this type of traumatic injury that may lead to ascites if left untreated.
Answer, please.
Let's go with 5.
Was there an answer there? I didn't hear it.
Yeah, he said bi-leak in.
Incorrect. Pair's chance to steal.
Agree. What is an arterial portal fistula?
That is correct.
That was a 1,600 point swing, guys.
Mental math. Okay.
So you can see on the more delayed phase that there's a portal venous filling on that angiogram. All right, so I believe pairs is stolen.
That's correct.
Choose.
Next. Go ahead.
I'm going with ANSEF 1000.
Young carp. Oh, sorry, my bad. Sorry.
No, you're trying to steal the spotlight, Sean.
So-
I thought we talked about this before. No, this is a young carpenter presenting with pain and paresthesias. This diagnosis is represented by these angiographic findings.
Hypotenor hammer.
That is correct.
Nice.
You have repetitive arterial trauma, and you basically develop digital ischemia in the fourth and fifth digits due to supply of the ulnar artery, which gets traumatized in Guillaume's canal. All right, so that was for 1,000. So is that 2,900 for Philly and 4,400 for NESIR?
Correct.
All right, this race is getting close.
All right, we're gonna do the last two guys.
Can I do cancer killers for 800?
Two absolute contraindications to performing TACE.
Would be an allergy to contrast dye and hepatic failure.
I would say incorrect. The contrast dye allergy could be mitigated with pre-medication. And I know this is kind of one of those what am I thinking questions, but we'll swing it over to
Chance of steal?
Yes.
You technically are.
What is portal vein thrombus and acute liver failure?
I would say that's correct.
I would agree. Yeah.
Multiple absolute contraindications to TACE. The final question for double jeopardy going to NESIR. In a non-cirrhotic patient, portal vein embolization is indicated when future liver remnant is less than what % of the total liver volume?
What is 45%?
Yeah, I also forget the answer.
That is incorrect.
Chance to steal.
Confer.
Is less than or something. What do you want to say? What is 30%?
That's getting closer, but still incorrect.
20%.
The not cirrhotic.
Okay.
Not cirrhotic.
All right. So with the end of double jeopardy, the score is New England Society of IR 4,400 and the Philadelphia Angio Society 2,100.
Yeah, that's what I have as well.
So just like in normal Final Jeopardy, we're gonna go with the topic, and you're gonna get someone set a timer for 30 seconds to choose how much you want to bet. The topic is vascular and interventional.
So you guys, do you guys know how much you want to wager?
Just confirming, it's 4,400 to 2,100.
Correct. Yes. So NESIR is 4,400 and Philly has 2,100.
We've got some gamesmanship over here at NESIR.
And the minimum bet is 300.
We're wagering 100 or $1.
Can they also draw something like a smiley face as they're giving the answer?
There's no. Yeah.
Does everyone have a value that they're going to bet?
Yes.
All right, here we go. Jan, you want to take it away on this one?
Absolutely. So a 39-year-old female presents for transplant kidney biopsy. She had a renal transplant 4 years ago, secondary to proteinuria and concern for rejection. The creatinine has been 1.3 to 1.7 over the past year, although this is elevated from years prior. A renal ultrasound with Doppler is without hydronephrosis or abnormal parenchymal appearance, but is notable for a lower pole resistive index of 0.54. During casual conversation with the patient prior to the biopsy, she states that her biggest complaint is her unilateral right lower extremity swelling and pain that sometimes wakes her up at night and is not improving, even though her transplant surgeon has been increasing her Lasix dose over the past 6 months. This single entity most likely responsible for the lab and physical exam findings seen here. So the lab findings would be the elevated creatinine, the resistive indices here, and the swelling symptoms. That's not the unilateral swelling symptoms not responding to diuresis.
Because you guys have to discuss as a group.
Oh yeah, hold on one second.
Yes, I can, if I can.
All right. Time is up. So we're gonna, I guess Philly will go first because they're the trailers.
Wait, do you guys have an answer? You have a final answer? Okay. How about you just tell it to me? Just okay. All right. They have their answer.
So Philly will answer first, I believe. It doesn't matter because everyone's answer is declared, correct?
Yeah.
Okay. Go ahead, Philly.
Like a renal transplant arteriovenous fistula.
And how much did you wager?
All of it.
All of it.
Right.
Oh, go big or go home. Well, Philly, that is correct. And that puts you up at 4,200.
4,200, yes.
And wow, this is really getting, there's a lot of suspense here in the audience. Now we're going to move it over to NESIR.
Their answer was renal AV fistula.
What was the wager?
$1. $1. Oh, come on. Sean is offended.
All right, so the final score. New England Society of IR, 4,399 NFTs. And Philly Angio Club, 4,200 NFTs.
No, I had 4,401.
Oh yeah, that's right. Plus
so New England, please expect your cash payout to arrive in another denomination that doesn't have the same value as the American dollar. But no, in all seriousness, that was really great. And
John, let's see it.
We'll go over the images here. Yep.
So on the right image, there's a aliasing artifact in the lower pole with the yin yang sign. I'm not sure what the finding is there on the left, Dave, if you want to comment.
It's so that was the ultrasound from years ago. You can kind of see a little bit of aliasing in like just the margin of the Doppler window, but then obviously it's grown over the few years when she came for the biopsy. We diagnosed it and then we brought her for the angio. Here we have a selective angiogram showing the fistula with reflux down into the external iliac vein, common femoral vein. Obviously, what's causing her swelling, her unilateral swelling, which was clearly not getting better with Lasix. We understand why. Probably also adding to the renal dysfunction, both the Lasix and the steel kind of from the lower pole of the kidney. Which got better after embolization, as did her symptoms. And we see some varicose veins there also in the right leg. Yeah.
So bottom line is everyone did a really great job from all levels. It was a great time, and hopefully we can continue this tradition with maybe some other teams can beat us out in the semifinals next year. But and I want to give a shout out to BackTable for helping us out, getting this promoted and on YouTube live. It'll be recorded so it can be watched back. So you can kind of go over the questions for if there's any trainees on that want to review. I also want to give a special thanks to the people that worked on the team to get the Jeopardy together. Mike Sheng, Emily Cuthbertson, Dave Guez, and obviously Jan. It was a pleasure working with you guys. And Kieran from BackTable, he was our AV guy today. He really helped us out. And of course, Ali Behetti, she did a great job. And I guess that's a wrap.
Yes, thank you all for participating. You guys, the residents, you did a wonderful job, and I hope this was educational for you and for the audience. Thank you all.
Thanks. Here's our references. A lot of them. All right, everybody, and thank you for the viewers watching at home. We hope to